And I want to thank the Department of Surgery, especially the Innovation Council, for allowing us to do this work today and supporting it. I'm Cindy Kinn, as you know, and then we have a lot of our team here. And you'll hear from both Zayi and Kim as well today. So just first to talk about our team, we have people from Stanford Surgery, we have people from the Virtual Human Interaction Lab at the university level, Jeremy and Brian Beams, Stanford Medicine and the Palo Alto VA, Carl Lorenz and Nick Andrade are in the back there. Christina Kenny is a PhD who was doing her dissertation in the use of VR for post-op pain in colorectal surgery patients at UCSF. So she also joined our team. And we also have our physical therapists from Stanford Healthcare, Elham and Eunice, who were instrumental in this project. So as you know, everyone's talking about the silver tsunami, it's upon us. And so that coupled with increasingly sedentary culture in this country really leads to a lot of frail surgical patients. We know that prehab and rehab are helpful, certainly for functional outcomes, but in also some cases helpful for long-term oncologic outcomes and complications. The main limitation to prehab and rehab is adherence and patient motivation, also access to exercise equipment, exercise coaching. Most surgical clinics are not equipped to do this, and the high cost of forming these programs really has limited widespread implementation. From our prior studies where we've interviewed patients and enrolled patients in our studies, we have found that patients really do want prehab and rehab. They want to know what to do before surgery. They want something to do to give them some control over their lives where they feel really vulnerable. And they're mixed in terms of whether they want high tech or low tech. You might, assume that patients who are younger want high tech. They want more gadgets. They want, apps and that sort of thing. And patients who are older tend to want more low tech, high touch type interventions. Everyone wants to do it at home. No one wants to come meet us and hang out with us and do exercise with us. No one wants that. It's interesting, actually, that a lot of the European studies have, these intensive programs where patients come and do, 3 times a week exercise at a hospital gym, which, we don't have. So, but everyone wants to do it at home. Everyone wants coaching to some degree. Everyone wants things to be kind of personalized for them and for their surgery, but they do want flexibility. Like, they don't want us to tell them everything to do. They want to have some control over what they do. So the need that we saw was a way to deliver engaging and convenient prehabilitation and rehabilitation to surgical patients. And we thought a potential solution was the virtual reality platform, which may offer the convenience of a home-based program with the benefits of an engaging and personalized experience. Oh, also in the back, there are VR headsets and wrist weights. So you guys just feel free to pop up and go check it out, put on a headset, try to remain safe and don't run into anything. Just sit down and do the exercises, but feel free to do that while we're talking. So the aims are to determine the feasibility of a VR-based prehab and rehab program, to determine its acceptability, and also determine how it affects accessibility to physical therapy. So why do we choose breast surgery patients? So it is a highly prevalent condition. A lot of patients are getting breast and axillary surgery, and many of these patients have upper extremity functional issues after surgery. So we thought that this would potentially be a good target with a large scale impact. And then also, importantly, since this is a pilot study, we really didn't want people to be running into walls, tripping over pets that kind of come through while you have the headset on. Anyone who's worn a VR headset knows that there's a high risk for those sorts of incidents. So we thought that if we focus on upper extremity function and mobility, then we could have people do seated exercises, and that would be more palatable to the IRB and allow us to sort of work out a lot of the VR and remote kind of difficulties and challenges without worrying about people injuring themselves. So we have two phases to this project. Phase one is, we call it the pre-pilot, and this was an on-site situation. So we had 10 patients who had already undergone breast or axillary surgery. We had them come to the virtual human interaction lab at Stanford to test the program that we had created, and then we interviewed and surveyed them to see what they thought of it. Based on their feedback and our experiences with this pre-pilot cohort, we iterated on the program. We then entered phase two, which is the randomized pilot study. This is the remote side of the study. So these are patients who are going to be at home doing the VR routine. They're all pre-op patients. We're recruiting 30 patients, randomizing them 2 to 1. We hear more about the design, but essentially 20 patients will go into a group where they're getting the VR program plus access to live PT sessions on Zoom. And then the other 10 will have VR only. And then we do interviews and surveys throughout the study. So just a little bit about how we created the VR content. So we had 2 physical therapists who are inpatient physical therapists. You might have seen them walking around, seeing your patients. They designed several modules of upper extremity exercises for breast surgery patients, and they performed and instructed patients on how to do the routines. We recorded them and then used Runway AI to green screen them, and then this is actually what Nick Intermonte in the back in the black t-shirt, he did all of this, created environments in Engage, which is a virtual reality software platform, and then added the video on top of it. Then we kind of tested and iterated in the lab, focusing on user interface, user experience. We also realized that, the exercises were a little bit, a little easy. They would probably be good for some patients, but some patients might want more. So we added the wrist weight option. So you guys you can go back and check out the wrist weights and try them out. And so when we arrived at sort of our final product for the pilot. So I'm going to have Zai, who's a rising 4th-year medical student applying in surgery, to talk about our results.
Thank you very much for this opportunity. Now I'm going to talk a little bit about the results from our phase 1 pre-pilot. So as Dr. Kim mentioned, for phase 1 pre-pilot, we recruited 10 patients, brought them on site, and walked them through one of these VR sessions. Here's the demographic of our phase 1 participants. As you can see, they're all post-op from breast surgery. 9 out of 10 of them are female. One of the first things we looked at is whether or not our VR session triggered any of the following 4 symptoms for them, which is nausea, headache, blurred vision, and dizziness. These are symptoms associated with motion sickness and has been reported to be triggered by VR content. As you can see here at baseline, none of our patients had any of these symptoms. And after the VR session, one of the participants reported blurred vision. However, this is most likely due to the fact that she normally wears glasses and preferred not to wear glasses with the VR headset. So therefore, when she took off the VR headset, her vision was blurred. So from this, we concluded that our content is safe for patients. So one of the first things we did after the VR session with patients is we surveyed them with this user experience survey. So this is a 9-question survey that we designed ourselves, looking at participants' perspective on the VR experience and their attitude towards using it for prehab and rehab purposes. As you can see here on the right side with all the green, patients in general responded very positively to the VR content. So as you can see here, patients reported that they liked the VR experience, they liked the headset, they liked the image qualities, and they would consider use VR again to improve their arm ability, their arm strength, their pain and anxiety. And most importantly, that they would consider using VR at home for prehab and rehab purposes. So from this, we concluded that VR is an acceptable way to deliver prehab and rehab content to surgical patients. The second survey we administered is a system usability skill. So this is a validative tool, consists of 10 questions that is used to assess the ease of use of a system or product. As you can see here on the left-hand side, for this survey, the odd number of questions are positively worded and the even numbered statements are negatively worded. And as you can see on the right-hand side, in general, patients responded very positively on this survey as well. The system usability scale can also be used to calculate a score between 0 to 100. The higher the score, the easier it is to use a system or a product. On here, you can see the score of some common home healthcare devices graphed here. For our VR-based prehab and rehab in the phase 1 phase, we got a score averaging about 75 from all the participants. And this means that we're slightly easier to use than an EpiPen and a blue glucose meter, however, slightly harder to use than an inhaler and a thermometer. Here's a graph just looking at system usability scale for just all products available to the public. As you can see here, Google search with a score of 93 is the easiest to use, and Excel with a score of 57 is very hard to use. So with a score of 75 for our VR-based prehab rehab, we're slightly too easier to use than a PowerPoint or a DVR, and slightly harder to use than Word or an iPhone. So from this, we concluded that VR is a feasible way to deliver prehab and rehab. So that's kind of the quantitative results from our phase 1 pre-pilot. Now I'm going to talk a little bit about the qualitative results from our phase 1 pre-pilot. So after the participant went through the VR session as well as the 2 surveys, we also conducted one-on-one semi-structured interview with them that lasts about 20 to 30 minutes. From the analysis of the interview, 4 main themes emerged. So for the first theme, patients in general have a confusion about why they need prehab and rehab. The first point we found from this is that before surgery, for many of them, mental stress often trumps physical concerns. So from the quote of this patient, before surgery, her mindset was more worry. She also didn't have as much symptoms that required exercising. So before surgery, her mindset was just worrying, praying, and hoping in positive reinforcements. The second point is that there's a need for motivation and rationale to exercise. The quote here we have for one of the participants is that for older adults, it's often very hard to encourage them to move around. But if the VR device is there, they'll at least have motivation to do something. So that is kind of the first main theme, which is there's a misalignment between patients and providers about the need for prehab and rehab. The second main theme we identified is patients talking about why specifically VR as a platform. And we find that user experience depends on the perceived necessity of the VR platform. The first main point is that the immersive nature of VR is very enjoyable to patients. So from this quote, we see that for this participant, they really like that they're somewhere very pleasant, it's near mountains, it's near lake, there's a deer, and they really liked how real it felt. The second point we identify is that VR content should really be VR specific, or in other words, really harness the unique capacities of the VR system. Otherwise, it feels extraneous. So during one point of the pre-pilot for this participant, they almost felt like they're just watching TV in the VR setting, and they're just like, oh, that's kind of weird. Why don't we just watch TV? The third main thing we identified is that successful engagement requires technical support and specific personalized coaching. The first point is that technical assistance is required because new technology can be very intimidating. So for many of our pre-pilot participants, this is the first time they've ever interacted with a VR system. So they thought if they didn't have any proper help from our supportive research staff, they may run into a lot of challenges. The second point is that coaching, progress tracking, and individualized exercise routines are preferred. This participant talked about that, just the fact that everybody is so individual, and then you can't really give one exercise routine to everybody because everybody's different on their restrictions, their pain level, and how they handle pain, especially after surgery. So that's kind of our first 3 main themes, which is patients talking about why they need prehab rehab, why using VR to do that, and the kind of support they need to be able to do it successfully. And that leads us to our last main theme, which is that VR as a novel platform has great potentials for perioperative physical therapy, but however, some really important drawbacks that we as providers should know. The first point is that VR really mitigates barriers to traditional PT, such as long wait time and commute. So this patient talked about how she would probably recommend it for many other patients, especially if they cannot go to a PT clinic, their copay is too high, or they don't want to leave their home anymore, or they're immunocompromised post-op undergoing chemo and shouldn't be going out and about. The second point is that VR may be a helpful strategy for perioperative anxiety. So for this participant, she talked about how before surgery, she was just really, really worried and had a lot of anxiety. And VR for her would be just so calming before surgery to calm some of the nerves. Lastly, for VRPT, the drawbacks mainly relates to hardware, which is the a little bit heavy headset, and the lack of individualized feedback and manual therapy. So some of the patients talk about during pre-pilot that they felt that they weren't really getting any feedback on whether or not they're doing the exercises correctly or not. Okay. So from the interview results, we made some iterations in preparation for our phase 2. So the first thing we added is a step for clearance by the care team after surgery for patients before they started the rehab phase of VR. And this is because we found that patients really require that reassurance after surgery before they feel comfortable and confident enough to start moving and exercising. The second is we improved our VR content to make it more smooth and more immersive and really take advantage of the capacities of the virtual reality system. Thirdly, we added in 6 different environments for patients to choose from where they choose to do their exercises. And this is due to the fact that patients really desire some sort of personalization and individualization. Fourth, we added in a tech support through a Google Voice number, and as well as really detailed instructions on paper and digital forms for the patients. And lastly, we added in the component for weekly PT Zoom sessions to try to mitigate the lack of real-time feedback in the VR PT setting. So this is kind of final product this is kind of the final product we created for phase 2. So this is our VR prep program, which is a program over 12 weeks, 4 weeks pre-op, 8 weeks post-op. These are exercise modules designed about 10 to 15 minutes per module, and we recommend patients to do them at least 3 times a week. And as you can see here, patients have the option to choose the environment they do their exercise in, whether it's in a traditional PT room, on Mars, or in a forest.
Okay, so I'll wrap up briefly with talking about implementation of this phase of the pilot. So this is our phase 2 pilot where patients are randomized to VR sessions with or without the live PT sessions. And these are any adult patients undergoing breast and axillary surgery with the only important criteria of an absence of chronic vertigo or nausea and vomiting. And otherwise, just patients do need to have access to stable Wi-Fi and a space to sit and perform the exercises. This is a busy slide, but it shows the layout of our study. There are 4 preoperative weeks and 8 postoperative weeks with a clinic post-op visit where the clinic team clears patients to undergo the rehab portion. There are 2 groups of participants, one with the Zoom PT and one without. And all patients undergo a series, they complete a series of validated measures, including a variety of surveys that include like arm, upper extremity function at home, frailty, anxiety, and other physical activity questionnaires. Patients have a semi-structured interview right before surgery and upon completion of the program. And throughout, there are weekly phone calls by blinded assessors to look at their experience. Now, throughout the intervention, through the device itself, we monitor use. And so this is an example of an actual participant and how much time they're spending using the device, and then added to the phone assessments. I have to say the implementation has been quite enjoyable and surprisingly easy in the clinic setting. We did partner with the clinic throughout to do demos with the clinic staff. So as patients are hearing about this, they're going to have questions. So we thought it was important that our nurses, our MAs, our PAs all got a chance to also experience the VR platform. And actually, I'll point out, I had never put on a VR headset ever in my life before this. Most of our patients that we're recruiting are not necessarily familiar. We've had a couple who were like software engineers and particularly motivated, but most maybe had very limited exposure, were kind of interested and heard about it. So it's been surprisingly easy to recruit to because people are curious. And same thing with our staff. So integrating into the clinic workflow to come up with a pattern that we could easily recruit patients during the span of their normal visits was important. Of course, we do all have space limitations in our clinics. We don't have a lot of extra exam rooms or space to house our research team, but we were able to work this out so that the team was there to supply patients with the headsets in real time, or we can mail them to them, but we're trying to recruit them while they're there at a pre-op visit. So this is a picture of my nurse in the Palo Alto clinic with our research team trying on the headsets. So we had a lot of fun doing this with the clinic staff. So for our phase 2 study, in our first 4 weeks of recruitment, we've consented and enrolled 10 patients. Like I said, it's been surprisingly easy to recruit patients. They're very motivated, first of all, to try out VR, and second of all, to do anything that might help in their post-operative recovery. We have found patients undergoing a minor procedure like a breast biopsy or a lumpectomy are not so inclined to sign up for a 12-week program for what's a pretty minor procedure, whereas patients undergoing sentinel lymph node biopsy, axillary dissection, and mastectomy are much more inclined to sign up for this duration of the study. Also, kind of interestingly, so far in our first month, the attendance for our live sessions is actually quite low, but participation in the headset is quite high. So we've had many patients and providers comment like, well, it seems like people really want that human interaction with a physical therapist. So we've added that to this study, and actually not so much so far on attendance in those sessions, but a lot of engagement in the app. And quite interestingly, we were concerned about patients being able to do this at home all by themselves, because our pre-pilot, everybody came to our lab and we showed them, and it was very handheld. And okay, they're gonna go home with the headset and they've got to put it on and do it. I personally needed tech support, and yet we've actually had 0 tech support calls from our patients thus far. So from a feasibility standpoint, it's been quite easy for patients to start using. Of course, we have some limitations. VR is an incredibly rich experience, but our design, which please put it on and try it, it's a little bit limited at this state based on the platform we use and just our ability to design something really immersive. For example, our patients, from the safety of avoiding falls and injury, they are seated and doing upper arm extremity exercises, but in the virtual world, their avatar is standing. So like you look down and you see your feet and you're standing. So it does slightly, question the reality of that virtual space, and you can't yet personalize your own avatar yet. We've heard that actually from a lot of patients, like, oh, I would never wear those shoes. So in this particular instantiation of our version, you can't change your clothing and things like that. You can't personalize it. And then importantly, there are other there's a lot of rehab research, for example, in stroke patients, where you have sensors all over the body and can quantify in 3-dimensional space how the limbs are moving. And of course, in the upper extremity, for us, we know where your controllers are and we know where the headset is. So you have a sense of where the hand in relation to the head is, but there's much more rich kind of 3-dimensional data that could be quantified in this system, for example, with sensors all over the body. The idea for this pilot phase is all about feasibility and can it be done? But future directions would be looking at, of course, efficacy of the VR intervention on actual upper extremity functional outcomes. Our group and others have a lot of ideas about future directions for the use of VR in this perioperative period. For example, we've heard from a lot of patients about the potential use of VR for helping to mitigate anxiety, insomnia as patients undergo treatment. There are nurses in the Lane Surgery Center that have reached out to us as a potential collaboration for a VR intervention in the pre-op and PACU for both anxiety and pain, and even looking at use of sedating medications and narcotics. Use, of course, of VR in the hospital setting or at home for specific post-op pain. And lastly, there are really rich, immersive, fun platforms for cardiovascular fitness in VR, and for patients looking who need to improve their cardiovascular fitness, and to try to improve upon frailty prior to surgery, one could envision a VR prehab intervention more focused on fitness and not just upper extremity. So we'd like to thank the large group of collaborators and especially the Innovation Council, David and Carla, for the funding support.